So there are recommendations for prompt EEG monitoring in the AHA guidelines. There's also some recommendations from other articles. EEG monitoring for seizures, status epilepticus should take place as early as possible, especially during the rewarming phase of TTM. We like to get ours on as soon as possible and monitor through that long continuum so we can, hopefully you're going to see some background activity appearing early, which is a positive signs. And then as the neurologist, epileptologist, and neurointensivist can determine, the presence of seizures, is the activity changing as the patient progresses from 24 to 48 to 72 hours. Continuous EEG monitoring should be continued for at least 24 hours after seizures and status in patients who fail to recover consciousness. So these are all recommendations that you find in the articles that are listed. Berg et al. In the 2020 guidelines did have some information that they outlined related specifically to seizures and EEG patterns, and those are found in this particular section of the presentation. So the suggestions that they make, we suggest against using the absence of EEG background activity alone to predict poor outcome in adult patients who are comatose after cardiac arrest. They suggest using the presence of seizure activity on EEG in combination with other indices to predict poor outcomes. So that's a really important point. It's not just one modality, right? It's multiple modalities as you're looking towards neuroprognostication. The specificity of the American Clinical Neurophysiologic Society defines seizures on EEG for predicting poor outcome as 100%. The specificity was consistent throughout the first 72 hours after return of spontaneous circulation. So they also suggest using burst suppression on EEG in combination with other indices to predict poor outcome in adult patients who are comatose. And what's important is that the effects of sedation have been eliminated in your patient population.